Oh, hey, Chris.
Hey Chuck, how are you?
I am doing really well. I am in a new location.
Yes, it looks like a very different location than your posh normal basement. It looks like a basement that is perhaps sparse or Spartan, some would say.
I don't think anyone would call my typical basement posh, but I am. I'm in a basement in my childhood home in Alabama. We are recording on the Saturday after Thanksgiving, and I escaped to the basement early this morning to talk to you.
Excellent. Thank you. Thank you. Did you have a nice Thanksgiving down in Alabama?
We did have a nice Thanksgiving. My pretty much my entire family lives here. And so we had a great Thanksgiving, saw some other people, and it's been nice. It's always nice to be home.
Is there one irrefutable, indispensable Goldfarb Thanksgiving tradition, either with the meal or anything else that you think is special or maybe even unique?
It used to be, well, two things, Chris, of course. It used to be that we would play a family soccer game, and that went on for many, many years instead of the traditional football game. We haven't done that the last couple of years. That was super fun. And then I guess from a food item, there's two dishes that I think really characterize our Thanksgiving. One is yams. They are prepared in I don't know, I think a little bit of a different way. Heavy on the butter, heavy on the brown sugar, very, very, very sweet. And then the stuffing is more bread-like and less sort of dry, which I think all of us have gotten used to. Maybe it was unintentional to start, but it's part of the tradition now. What about you?
Well, I guess the tradition now is me struggling to find a way to cook turkey that everybody will eat. And inevitably it ends up being the same people eating turkey, no matter how I cook it and how delicious or not delicious it is. But so this year was chicken fried turkey, which was amazing. And makes amazing leftovers. I'm not gonna lie, it was really good, but only a couple of people got to try it. But it's been fun. The yams sound delicious. They sound traditional in terms of tons of butter, tons of brown sugar, in terms of at least how I've had yams in the past.
So wait a second. Who doesn't like turkey? Is this the kids don't like turkey, or
I think my wife just doesn't like the taste of turkey itself, like the texture of the bird, the meat. So it tends not to be a hit. So then if nobody else is eating, it's just me and my father-in-law, then the kids that tend not to eat it. They go heavy towards the mac and cheese.
Thanksgiving dinner is really interesting. I think everyone can talk about having the same type of dish, but it is very different family to family. And I think it's hard going. So, Talia, we have always done Thanksgiving at my house. And it's so funny how it's so called my house at in Birmingham. I don't live in Birmingham. I live in St. Louis, and I've lived there for a lot of years. Talia's Thanksgiving is less important to her family, less consistent. Her family tends to disperse for Thanksgiving. But for the Goldfarbs, it is Thanksgiving with our typical dishes, and I really enjoy it.
I will say before we move on, I do love stuffing, and we had three kinds of stuffing this year. One is an actual stuffing, like inside a bird. I roasted a chicken just because you have to roast some kind of whole bird, and it was delicious. And there was one stuffing that was inside the bird, and the bird was sitting on top of it. There was another kind of stuffing which was cooked completely separately. Then there was a third stuffing that our friends brought, and it was heaven to have so much stuffing. It was great.
How many people did you have at your house?
Not many, no, just another one other family. So it was a total of 10 people, which was super fun and enjoyable. And because I was on call, we did it for lunch. So I was up at 5-ish, getting the ovens ready, and I worked out while the ovens were preheating. While one of the I roasted a pork shoulder, so that was going while I was working out, and then it was basically 5 until noon. It was just like it's kind of like a day at the office, just like nonstop going, 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 and then I actually took my apron off and looked at my wife and I said, "I'm done," which I don't think I've ever like just been like, "I'm done," but I was done. So
For,
I was gifted an extra half an hour because our guests forgot something at their house, so they had to run back. So got everything done perfectly on time, which was great.
for any listener who does not know about Chris's excellence in the kitchen, all you have to do is follow him on Instagram because there are regular, almost daily posts, certainly
I
every
should
time you
probably
cook.
post about hand surgery. I mean,
I'm not here to tell you how to handle your Instagram account, but your foodie account's pretty good.
Oh, it's just so much easier to post about the food. Anyway, so
Yes.
we should finish our series on radial nerve palsy. But before we do, we have to talk about our friends over at Practice Link. I got a text the other day from a friend and fellow listener, Micah St. Clair, saying you got a sponsor. So super excited that that you and I have been sponsored by Practice Link.
Absolutely. It has been fun relationship thus far, and we hope it's been mutually beneficial. We certainly have enjoyed it. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. So join Practice Link for free today at www.practicelink.com. But you should get all of your radial nerve palsy tips from Chuck, particularly for tendon transfers.
Absolutely, but I do have to slightly correct you. We are going to have one more part of this segment because don't forget Macy and the therapy that follows tendon transfers and nerve transfers.
Or the decision making that precedes your tendon transfers and nerve transfers. I remember one particular moment, and she'll kill me for saying this, but in nerve clinic, Macy pulled me aside and said, "Thank you for fully treating me as a colleague in this clinic." And I was like, wow. I was like, really, I was like, of course. She's like, we're in this clinic together. We're doing this together. I'm seeing patients with you. And I'm a therapist here. And I'm like, I love that. Like, that makes me so happy that like that we're working on this together. And I think a lot of it is because like there are times where I'll say, I don't know, Macy, like go in there and let me know what you think, because I don't want to put this patient through a huge reconstruction, nerve based. And then at the end of the day, they're either going to have wanted tendon transfers or don't have the wherewithal to complete all the therapy that comes with the nerve transfer. So that piece of it's really, really important. So I'm looking forward to discussion, not only about how to do the therapy afterwards and pearls about that, but then also how the decision making that goes through their minds, or at least Macy's mind, from a therapist perspective.
Yeah, for sure. It brings up an interesting point. I guess I can't even conceive of a relationship with therapists that's any different than the one you described. That is completely collaborative, and I think I was raised on that principle with Dr. Mansky. As a congenital hand surgeon working at the Shriners, where we absolutely um, valued is not good enough, but valued the opinions and followed often the recommendations of our therapists regarding appropriate surgeries. And that's certainly true for cerebral palsy, but for many other diagnoses. Little known fact for those of you who are bigger fans of Macy than Chuck and Chris, Macy is also from Birmingham, Alabama. And we were out for the turkey trot. And I was watching the turkey trot because I'm having surgery this week on my knee, and but my kids were running and family were running, and I saw Macy's husband, her adorable son. I met her father, so they were out for the turkey trot as well, which was super fun. Macy was not there, but I got to hang out with their family at least briefly.
That's amazing. I thought you of all people, right before your surgery, would probably try to stir up a little inflammation.
I
Get
thought about it. I
the
thought
last
about it.
turkey trot done. Kind of really rev the milieu for your surgeon.
I think you'll have plenty to work with. Uh, too
So we
funny.
left off at the last episode with a lot of pearls about nerve transfers. Actually, I've been thinking about a few more, so maybe we could do a wrap up at some point as a bonus potpourri. But I think that ultimately the tendon transfers are what most people should get. I think my ratio is probably higher in terms of doing tendon over nerve. But unfortunately, a lot of trainees, and I'm biased, but many will go throughout their fellowship without actually seeing a lot of tendon transfers, just because many of those cases that would have been automatic slam dunk tendon transfers are now shifting towards more of a nerve basis. And a lot of that's based on who you're training with and what you're seeing. But a lot of people, I think, do want to come see the nerve stuff with us. We do a fair bit of it volume wise. So I'm happy that we do it, but I think that there are people who are going to go into practice and aren't going to do nerve, that should know how to do radial nerve tendon transfers.
It's interesting. I'm not suggesting we do a survey, but I would have thought that I would guess it's 80-20 tendon transfer. Am I just that far out of the loop? Do you think it's if you look at all hand surgeons, what's your perception of what percentage are doing nerve transfer preferentially over tendon transfer?
It probably is close to 80-20. And even if you look at individual surgeons, like in my practice, like I remember when I talked to, I was hosting some kind of pre-course for the Hand Society on nerve versus tendon transfer. And I was on the podium with Dr. McKinnon. I actually asked Dr. McKinnon, this was probably about 4 or 5 years ago now. And I said, what's your ratio in terms of tendon versus nerve? And at that point, which was, again, not recent, but she said it was 4 to 5 to 1 in terms of tendon to nerve. So while the nerve transfers get a lot of airplay, and like we talk about it a lot, at the end of the day, you're probably going to do more tendon transfers than nerve transfers, for some of the reasons we stated earlier, and then also because of timing. Patients oftentimes get to us a little bit late, unfortunately. But I think if you took a survey of practicing hand surgeons all over, you would see more tendon than nerve. It's just, the stuff that gets published now and talked about and presented about is more nerve based just because it's newer.
I totally agree. Yeah, and in academic centers, maybe there's one of those situations where the trainees are seeing a bit more of the nerve transfer, to your point, rather than the tendon transfer. When they get out into practice, they may choose the tendon transfer. In my practice, in general, as I've said, I don't do a lot of nerve transfer, occasional selected nerve transfers, but I do a fair amount of tendon transfer. Much of it's in my pediatric population with cerebral palsy and with congenital deficiencies. But I think all of us, unfortunately, for better or worse, are do tendon transfers related to distal radius plating, etc. So it is an active part of my practice, and I like it.
So before we dive into details, is for a standard radial nerve palsy, is there ever any advantage for you to having the patient awake for the tendon transfers?
No, there's not. I understand why you might like that.
You're assuming that I like that?
I'm
I haven't
assuming.
even said. I just asked the question.
I'm
Jeez.
assuming. No, I don't think it's super helpful for me. The tensioning part of tendon transfers is obviously important, but it's not helpful for me to have the patient awake, at least in 2022.
Right, right. Well, I think the tensioning part is appealing, but oftentimes some of it involves some re-education, which they may not have gotten right away. So it's hard for them to actively fire something. It's not like it's a tenolysis where they already know how to do it, and it just takes you longer. Being awake for surgery that long is unnerving, to a vast majority of people once you're beyond like the standard 10-15 minutes or whatever. It's interesting. We're in the process of working with a company that makes a virtual reality headset for some of these longer surgeries, which would help a lot. But I have not found it particularly helpful for this. I just figured I'd ask because a lot of our listeners are into wide awake surgery. So, but neither of us are doing that for radial nerve tendon transfers.
No. One day. So when why don't you want to talk about the nerve transfer stuff now?
No, let's save it for the future. Let's talk about tendons.
Oh,
So
a whole
let's
nother episode.
yeah. Well, I mean, like let's we'll sprinkle it in at some point.
Okay.
Keep people wanting more, Chuck. Don't give them everything.
Oh, well,
So are you ever using anything other than pronator teres, if it's available, to restore wrist extension?
yes. So maybe just to briefly highlight, then we can go into the three segments we're working on. So the three goals, I think you will agree, are number one, wrist extension. Number two, control of the thumb or thumb retropulsion. And number three, finger MP joint extension. Is that fairly said?
Absolutely. I like the way you broke that down.
Perfect. So totally agree. Of those three, the most reliable, and I think universally pretty much accepted as the gold standard is the pronator teres. Any pearls on how you do that?
Well, I was going to ask you because every time I do this is one of the more, because I do it in both the tendon transfers and then also when we're doing our selected nerve transfers. This is the one where you kind of tell the trainee, you're like, all right, we got to keep this as broad and long of a periosteal tail as possible. Don't undercut it. Don't let it thin out. And then the entire time I'm letting them do it, I'm watching them, I'm holding my breath, waiting for them to undercut it, waiting for them to shortchange me. And last time I did it with David Wright, our fellow right now, who you went on a trip with recently to work internationally, and he was fantastic. It was a beautiful tale of periosteum. It was so good. So it was just one of those like affirming moments. You're like, all right, this is why you have the trainees do it so they can learn. But there was a lot of talk the whole time, like, all right, don't remember this has got to be perfect. So one thing that I do, and I don't know how much of this is the nerve thing, but I will release the BR and decompress it at the level of the superficial radial nerve, so that it essentially a tenotomy, the BR, for the recovering SRM, but then also so I can get really far on the kind of middle third, distal third shaft of the radius to get that pronator teres periosteal tail.
Interesting. I've not approached the BR that way. I leave it alone. Um, for what's always interesting every time we're in the OR, it's really easy to find the pronator teres, but it's always surprising. It is directly in the midpoint of the radius, the insertion that is, and finding it mid-radially works really well. But anatomy is always a little different, and so you have to work, figure out how to get down to the bone, isolate the tendon, as you said, really, really preserve as much of the tendon and periosteal insertion, and that makes the younger patient a little bit easier and have a good length of tendon to work with, because you don't have a lot of length to play around with as you transfer to the ECRB. But it's a great transfer, and I tend to weave it into the ECRB, the classic pulver taft. I don't always have enough, but we want, when I'm in the OR, I don't know about you, when I'm in the OR, I'm looking for tension at neutral. Even if it's slightly flexed, I don't mind, but really neutral. Green classically talked about tendon transfers with the wrist really extended. And for some patients, that can be appropriate. For most of my patients, I'm not looking for that much extension tensioning.
So you tension with the wrist in neutral, and do you go end to end in terms of the tendon, or do you put it into the side of the ECRB, wondering whether something's going to come back and reinnervate anyway?
I do I basically a classic pulver taft. If I can get 2 passes through the tendon, so I'm not cutting and realigning, I am passing it through the intact tendon. Do you do it differently based on your
Nope,
patient population? Okay.
I do the same. I do the same. And then also, so I tension with the wrist cocked up in about 30 degrees, because so I sew it in that way, and then I take it off. And when I'm looking for tension, because inevitably it droops a little bit, I'm looking for a little tension, a little bounce in the neutral position, and then I'll splint them back up in extension. So in terms of, we talk about this periosteal tail, for those of you that are less experienced with the surgery part of it, you're looking for the pronator teres tendon insertion on the bone, and it's a broad insertion. But if you only took the pronator teres tendon itself, when you go to transfer it to the wrist extensors, it will be short and you will not reach. So what many of us do is extend the insertion with the periosteum, and I tend to go to kind of the distal third of the radial shaft with it. But I incise very hard with the knife on the dorsal aspect of the shaft and the volar aspect of the shaft and make a little rectangle. And then I'll use, I don't know what you use, I'll use a combination of a knife or a number 9 for your elevator, the sharp portion, and then that wider blunt portion, to really get a nice tail of periosteum up to essentially increase your working length of that pronator teres tendon.
All well said. The only thing I would add is the other benefit of having as much length as possible is it helps your line of pull or your moment arm. If you have a short pronator, then you theoretically have to tie it in more proximally, which makes it a more transverse pull versus a longitudinal pull. And the other issue is you're always sort of right around the outcropper muscles, and just finding that sweet spot for where to tie it in can be tricky for certain. But I really did like how you described your tensioning assessment.
How do you how proximal do you go on the pronator teres musculotendinous junction in terms of mobilizing that? 'Cause sometimes you're tempted to just trim a little bit of muscle off of the musculotendinous junction to get a little extra length off of your PT, so you can land in the sweet spot. Is that a no-no for you, or is that something you occasionally will do?
I don't usually adjust the muscle. I do try to, put an Army Navy retractor parallel to the muscle and just release some of the fascia adjacent to the muscle to increase the excursion of the muscle. It's not a high excursion muscle in general. But I haven't done much with this one. Now, some of the other ones we're going to talk about, I will trim muscle, but for this one, I haven't done a lot of it.
So one other tensioning thing that I've found helpful is to make myself a little bump out of blue towels and Coban to keep the wrist in extension, during the surgery. So I'll hold it manually while we're tying in, but then after that, I'll take a stack of blue towels and then make it bigger distally, so balled up, and then put the wrist in the position I wanted with the blue towels over the wrist and the wrist kind of cocked back, and then co-band all that to the wrist and sometimes also to the MP joints to keep the MP joints in extension. And again, you can play with that to get it into more extension if you want while you're actually sewing in. But that just holds the position of it during the rest of the case. It's one less thing that I have to worry about. Although it's not exactly where I want it, it's better than letting it completely droop. And I don't know how I evolved to doing that, but it's always something that the trainees like to see. And they're like, oh, I didn't really think about that. It's like, oh, it just makes my life easier. It's less things I got to keep track of.
Yeah, I like that too. I really try to control the ECRB with maximum proximal force to really assist with that extension posture. And you really have to pull pretty hard, both on your transferred pronator and your recipient ECRB. Yeah, but it's just such a reliable, good transfer, and that's why pretty much every series of tendon transfers includes it. Um, how do you think about the thumb?
So for the thumb, I think that if you have it, I like using a palmaris longus if you have it. Not always present, but if you have it, it's fantastic. I think that I end up sewing into more of a combination of the EPL and the EPB, just because although I know the EPL tends to be more responsible for retropulsion. If an MP extension lag, as we talked about in the last episode, is a little bit bothersome to the patient functionally. So I tend to kind of sew into that as a group. What if you don't have a palmaris? What do you like to use?
I have done it different ways, and thankfully, we know the stats on absent palmaris 10 to 15% of the time. It is so easy when it's there because it does everything you want it to do. It's an easy technical transfer, and it does retropulse and abduct the thumb. It's a beautiful transfer, and certainly strong enough. You don't think about the palmaris as having a great deal of strength, and it probably doesn't have the same strength as the muscle it is replacing. But I go and I use just the EPL. I like what you said about the EPB, but I just use the EPL. When absent, I have done it different ways, and sort of depends on what else I am doing. I have used FDS, and I have used what I would say bigger transfers like the FCU, but I tend to prefer the FDS when palmaris is absent. What about you?
I've used the FDS, but I also know there are a lot of people that will honestly just include it with the finger extensors at that point. Because sometimes you're in a situation from trauma or whatever else where you don't have additional options, or you don't want to mess up the fingers, the finger flexors for other reasons because they're stiff or because they're not perfect or whatever other reason. So FDS occasionally, it just feels like a big thing to take, in terms of the finger flexors, but certainly expendable if you need to.
Yeah, and when we talk, I guess we probably should just mention classically when we talk about radial nerve tendon transfers, we sort of have three groups of transfers. First is the brand transfer, BRAND, and that includes the FCR as the main transfer for finger extension. We have the FCU transfer, which is can be more associated with the green transfer, and we can use that for wrist extension in kids. But I think when we talk about it here, it's the FCU series of transfers, and then the superficialis transfers were advocated by boys. So really, boys is superficialis, and brand is FCR.
And so with that in mind, what do you prefer in terms of using for your extrinsic finger extension, your MP joint extension, assuming median and ulnar are pristine?
So I think most would say FCR is the transfer of choice. The tricky part for me is because in the pediatric population with CP, we're looking to increase supination. FCU helps accomplish that goal. And again, in the pediatric population, I don't mean to confuse things, but in the pediatric population, we're often using FCU to ECRB to help with wrist extension. But I think if I'm doing an adult radial nerve palsy, it is absolute pronator teres to ECRB. When available, palmaris longus to EPL, and then FCR to EDC. That is my go-to, and I really like it. Certainly, you have to be flexible and be able to go in different directions, but that's my preferred.
Any pearls for harvesting FCR? I know that we've harvested FCR for many other things, including LRTIs, et cetera, but do you have any pearls on how to do that in the most efficient way?
Well, one thing that's important to say, I think, for all of these tendon transfers is that no matter how much you like little incisions, this is not the operation to use small incisions. You really need to change your moment arm, change your direction of pull, make sure the transfer muscle is fully released. And so a big incision. Now, if you're doing palmaris and you're doing pronator and you're doing FCR, you really are all on the radial side of the wrist. And so a mid radial incision can be really helpful as far as just having great exposure. And you just want to go as distal as possible. And so, when you're taking the FCU, you're taking it right off the pisiform. When you're taking the FCR, you're going right up to where the FCR disappears around the scaphoid. At least I am.
I agree, and I think that the big incision is key. And for me, for example, the last time I did this, when it was purely tendon transfers, I used a standard big volar approach. And then after we had tunneled everything through to the dorsal wound, then we closed the volar approach, so we wouldn't have to go back. And I think that's a pearl that many talk about, closing as you go, so you don't have to try to manipulate the wrist and the fingers to close volarly after you've tied in your tendon transfers. When we did it last time, we actually sutured, did our weave from FCR. Actually, our pronator teres to ECRB was done kind of through the volar incision, just because we had the exposure of the second compartment through that, and we did a more kind of dorsal midline incision to suture into our finger extensors and our thumb extensors.
Yep, love that. Exactly right.
So then, how do you get the tension just right for your EDC recipient?
Yeah, so I'm constantly, so you can overtension these. Let's just say that I've been guilty. But you'd rather overtension, assuming that over time there'll be some creep and some stress relaxation. And so you tend to overtension slightly versus undertension. And I'm constant. So I basically do the first limb of my pulver TAF weave, and then I check what things look like. And so what I'm looking for the fingers, and I do think that's the trickiest, is I'm moving the wrist. Now I've already done my PT transfer, so you can't get too much information, but you can understand what wrist extension does to the finger posture and what the tenodesis effect is. And so you're really looking for slightly over tensioned with the wrist and slight extension. Hopefully your fingers are up, meaning your MP joints are fully extended. That's what I'm looking for. Is that how you think about it, or do you do it differently?
Yeah, very similar. For those of you that are not watching the YouTube feed, Chuck is showing a wonderful example of almost like a hook fist. So the MP joint's kind of up in near hyperextension, and then holding them there and then checking the tenodesis. So even though you've already sutured in your PTD CRB, flexing the wrist and kind of seeing what that initial posture is going to be for the MP joints of the fingers as that wrist is passively flexed. Do you tend to set your cascade on the EDCs by suturing them all together before you inset your weave from your donor, or do you just kind of get them one at a time?
Great point. And absolutely, I suture them all together to start, because that tension in some ways may be more important. I don't know if it's more important, but it's a different importance than your actual tendon transfer. So I set the tension of the EDC tendons all together, and then I add the tendon transfer. Great point.
I think that if you're purely, there are some cases like a cervical or dick or something where I'm doing purely something for the EDC. And I think that's a great one to do awake to set the tension on those. And it's a smaller surgery. But I think setting the tension is key. What suture do you use? And if you can avoid using a brand name, that'd be great, unless J&J wants to sponsor us. But what do you use caliber wise and needle wise, if you remember, and material wise?
Yeah, I'm using a braided, so I'm using a non-absorbable 2.0 or 3.0, depending on the size of the patient and his or her tendons. I do like a cutting needle, although a taper cut is also fine, and a braided, whatever it's called, polyester. I don't know. It's not polyester.
Does it start with an E?
It starts with an E and ends with a bond.
I like using a tapered needle here in this situation for the for setting tension side to side. I'll use the 3/0. If for example, for the PTD CRB, I'm using typically an O or 0 caliber suture, and then if it looks like it's a little wispy, I'll augment with the 3/0. For the weave, I usually put 2 figure-of-8 sutures for each weave, and I try to get 3 weaves if I can. And then usually if we're doing for like it'll be 3/0 caliber suture for the thumb, and then for the finger extensors, it'll be an O and a 3/0, like, for each of those weaves. That's worked for me. It's always fun trying to guide our trainees through making sure that the sutures pass through each of the donors and recipients without cutting the prior suture. But our trainees are fantastic and they do a great job at that.
That's right. And one thing, so of all of this stuff, for the residents and fellows who are listening, when you go out to do a case like this, it's not going to be a case you do every day. And so you may review and read about the incisions and the muscle tendons you're going to transfer. The part that'll keep you up the night before and stress you out until you get done is the tensioning. And your choice of suture, your choice of incisions, all that stuff's important. The tensioning is what's going to stress you out. And so videos online can be helpful for that, but it's also common sense, and using tenodesis to assess positioning. I think you get more comfortable with the concept, but the first time you do it, that's going to stress you out.
Tensioning still stresses me out. So, and then we'll talk about this with Macy. But before we bring it to a close, I mean, when do you initiate therapy after these kinds of tendon transfers? Do you think there's a camp that will go very early? There's a camp that follows a standard 6 weeks of immobilization, and there are probably some people that fall in between.
Again, depends a little bit on my patient population. With my younger patients, with CP patients where spasticity of the muscles is an issue, I tend to go 6 weeks in a cast. In a younger, well, I'm sorry, I shouldn't say it that way. In a more typical radial nerve palsy from trauma or whatever, I'm not against early mobilization. I'll be really interested to hear what Macy has to say. But the flip side of that is I've never seen a patient develop long-term issues secondary to casting for 6 weeks. And so it's all about the convenience or inconvenience of casting for 6 weeks, which in the grand scheme of things, I think is not that big a deal. And so I tend to immobilize a little longer for these, although I'm not against early mobilization in the right patient.
Yeah, I agree. And I think that I tend to err on the side of immobilizing for the full 6 weeks, or at least a month. That's pretty dogmatic, but it's worked. And I think that if you include that in a preoperative conversation in terms of expectations, it's not a hard sell. You tell them that you want the tension is the tendons to heal. You want the tension to try to set as much as you can. It softens a little bit early, and it will stretch out over time. But as even though we say that these versus relative to nerve, the tendon transfers will get you going quicker. You got to make sure you build in that we're not going to move it right away. We're going to let it set for 4 to 6 weeks before we do anything else.
Yeah, exactly right. Exactly right. All right. Well, this is fun, but I definitely am looking for the fourth part of this wonderful series. Getting Macy on, we'll find a time. We'll get her on. There's a lot of different things that have come up that you and I want to talk about, but it's not going to all happen before the Christmas, New Year's holidays. But we got a lot of things to talk about. I'm excited.
Yeah, it's going to be heading into 2023 with a full head of steam for the upper hand, and we're excited to hear from any listeners that have any other questions. We have had a little bit of a dry spell on the listener email account, so please send your questions, comments, rants to Chuck at handpodcast@gmail.com.